circle. Good. Well, welcome to Walk with a Doc. This is July 17th, 2019. And to borrow a quote from a mid-19th century poet and philosopher, Henry David Thoreau, an early morning walk is a blessing for the whole day. And I think that speaks for today as well. Get your walk in early, get your education early before it gets into that real deep heat wave. Today, we start our 5th year, and kind of fitting that the very first event for the first year, a cardiologist spoke. That was me. And today, the first event of the 5th year, another cardiologist. So in a way to introduce Dr. Mooradd, Dr. Michael Mooradd and I have worked together at Central Bucks Cardiology for 21 years, side by side. He's a great speaker, and he has a great topic for you, talking about the PCSK9 drugs. Nothing to do with dogs or canines or anything like that, but it's another method of treating cholesterol. So, Dr. Mooradd.
Thank you for inviting me. I see some familiar faces. That's very nice. I was feeling jealous that I didn't get to talk about cannabis, because we're getting all these questions now. Can I use it? Is it safe? Well, we don't know. You know, it's all brand new, sort of brand new, taking us all back to our younger days. My topic today is a little bit drier, but just as important. We're going to talk about these new drugs that treat cholesterol, and they have a mouthful of a name: PCSK9 inhibitors. The PCSK9 abbreviates a very long enzyme that's in the liver. None of us try to say it, so we all go by this abbreviation. The two drugs that this apply to are Renexa and Proluent. These are the trade names of the two drugs that are out. But to just take a step back for a minute, remember, we're trying to treat heart disease in America or in the world. When we try to treat heart disease, there are 4 modifiable risk factors. Modifiable because we can affect them. Family history is a big risk factor, but you get what you get. And so the modifiable risk factors are diabetes, hypertension, cigarette smoking, and cholesterol. Hypertension and diabetes we'll set aside. Cigarette smoking, we've made huge inroads in America or in the developed world, and the usage of cigarettes is way down in this country, which is really an applaudable thing and a 30-year effort for public health in our country. Cholesterol is the next big thing, and it'll surprise you to know that there's 100 million people in America that have cholesterol levels above the guidelines. 100 million people with cholesterols above 200, which is the recommended level to try to stay below as a general guideline. And then, as you know, if you have heart disease, we set the levels even lower. But as far as modifiable risk factors go, treating cholesterol is huge. The number one way we try to treat cholesterol is with this. We call it lifestyle changes. That means exercise and diet. The number 2 way we try to treat cholesterol now in America are with statins. And everybody's familiar with statins. I think the 3 most common, Zocor, Lipitor, and Crestor. And so if your cholesterol is above 200, or if you have other risk factors, you know, we have other people we worry about. If they have diabetes, or if we plug them into a calculator and their risk score is high for heart disease, those people are on statins to try to drive their cholesterol numbers down. Not everybody gets to goal with statins, and not everybody can take high doses of statins. And so what do we do with those people who can't get to goal on a statin or can't take a high dose of a statin? That's the nut we're trying to crack. Typically, we use non-statin drugs. Zetia was a big drug in that sort of niche, and some of you may have been on Zetia or may be on Zetia to supplement the statins. But in the last 5 years, this new class of drugs emerged. It's a monoclonal antibody. That's what these PCSK9s are, monoclonal antibodies. It's a breakthrough way to treat cholesterol, because statins work inside the liver to try to poison a pathway that creates cholesterol. PCSK9s work outside the liver to allow receptors in the liver to sort of be blocked, so that they can't pump the bad cholesterol into the blood. That's the simplest way to describe how PCSK9s work. But the cool thing is it's not a tablet, it's a shot. So these drugs, again, Praluent and Praluent and, help me Jim, Praluent and, what's the other brand name?
I'm blocking right now myself.
So these two drugs...
While you were talking, how's that?
Okay. These two drugs are given by an injection that you take either once or twice a month. So you would typically be taking your statin medication every day, and then once or twice a month you give yourself an injection under the skin. It's a monoclonal antibody type drug, and it's slowly released from the injection site and works for 14 to 30 days. The effect of the drug is dramatic. It reduces cholesterol an additional, typically 50%, which is astounding. So if you're on, let's say, Zocor, and you're taking an intermediate dose and your cholesterol can't get below 200, if you go on these drugs, you'll drop your cholesterol precipitously. So when they first came out and we saw the effect they had on cholesterol, we expected them to be gangbusters. They've been a little bit disappointing in two regards. First of all, although they reduce your cholesterol dramatically, the benefit they have is a little bit smaller. They definitely have a benefit. They'll add to the benefit of the statin. So if you're on statin, you reduce your risk of having another heart attack, or you reduce your risk of having another stent. If you add the PCSK9 on top of it, you reduce your risk even further, but it's about 2% as an absolute number. So that was a little bit disappointing. The other disappointing part of the drug, honestly, is the cost. When the two manufacturers marketed this drug in America, the cost was $1,000 a month, sometimes a little bit higher. And it was really frustrating to the cardiology community. We don't have any influence on pricing, and when we were so excited to see these drugs emerge, we were really disappointed that the cost was quite so high. We can only speculate what goes into pharmaceutical companies deciding what a drug is worth or needs to be charged, but at that price, for that small amount of benefit, they had not been heavily utilized. Last year, those two manufacturers reduced that price significantly, but still in the range of $500 a month. So if you have this extraordinary insurance coverage, you can get the drug and you'll have coverage, and it's a really helpful additional cholesterol medication. If you don't have coverage and you're paying right out of pocket, you'll see that a lot of us still aren't wildly enthusiastic about having you go out and spend $550 a month for these drugs, because statins have gone generic, and if you want to do a very sort of actuarial view and say how much bang do you get for your buck, you get a lot of benefit for a little bit of money on the statins. If you can take the statins, they're the foundation of therapy, but if you can't take statins, if you can't get to goal on statins, adding these PCSK9 inhibitors, that's the next step. And we're just, as a cardiology community, crossing our fingers that the price will go down yet again. You'll start to hear about them more, you'll start to see them, and your doctor may prescribe them.
Side effects?
Mostly they're local, so the side effect in the liver hasn't been seen. They're extremely well tolerated. It's because you're injecting an antibody under your skin. The side effects are like those vaccinations we used to get, that we all hated to get our MMR, especially the second one, because you build up a little reaction to it. So mostly the complaints are you get a little lump, some people get pain and tenderness. That's the only side effect I've been aware of.
So the name is Repatha.
Oh, thank you.
Yeah, the chemical names are too hard to pronounce because they all end in MAB, which is monoclonal antibody.
Right. So Praluent and Repatha, those are the two brand names of the drugs.
Is it still 1 out of 5 of us statin users that do get the myopathy and mitosis? Probably one. I was one. After on statins, when I was 35, the guy said you have a hereditary cholesterol, so I started with the powders, the Questran, so for different ones my insurance would cover.
Yep.
I finally, after 20 years on them, the pharmacists were saying, yes, you're the best thing for your statins in your heart, and the statins.
Yeah.
So my muscles all broke down about 3 years ago. Went through therapy and all. Of course, I'm not. None of them. Now I wouldn't touch a statin.
Yeah.
Fine. I'm a little over 200. I have the ratio that's very good for, you know, you divide your
Good. Yep.
cholesterol by your HDL.
Uh-huh.
And if you're, what is it, under 4 or over 4?
For the ratio of HDL to LDL?
No, the serum to HDL, that ratio, if you're in good.
Yeah, if you're right. If your HDL is over 50, or if you put it into a ratio, that is a favorable factor.
But you can control it by your exercise.
Absolutely. Remember, that's
Your diet.
the first step is always that. Unless you already have had a heart attack or you already have a stent, and then besides exercise, we do encourage the addition of statins if you can tolerate them.
How about the AFib? Because they did discover AFib, so I'm on Eliquis.
Uh-huh. Statins and cholesterol medications aren't really involved in AFib. I think that's just a different electrical problem in the heart. But you touch on a difficult problem, which is the muscle pain that people get with statins. I don't think it's 1 in 5, but it's frequent. But the frustration is, you know, most of us wake up once in a while with muscle pain, and if you work out a little bit, you get muscle pain, and it's easy to blame the statin for the muscle pain. So we've got to be a team working together to see whether it's really the medicine that's causing the inflammation in your muscle or it's something else. They did do a big study where they took people who swore they couldn't take statins, they reintroduced them to statins. Some people absolutely cannot take statins, but a lot of people who thought they were intolerant or allergic ended up tolerating either a different drug or the same drug a couple months later. So, you know, you'll hear a lot of possibly negative things about statins. We spend a lot of time trying to convince people, stick with them if you can. If it's not bad muscle pain, if you don't have elevated numbers with blood tests, try to stick with them. But if you can't, or you're not at goal, these 2 new drugs may play a role for you.
And I guess sometimes your doctor's office can help you get started in terms of you're not used to giving an injection to yourself. Obviously, if you're a diabetic and you already do that with insulin, you have a leg up on that. But it's a challenge to do that. They're typically every couple weeks. It's not an everyday injection either, too. Any thoughts about how that plays a role with stroke or carotid disease or peripheral arterial disease?
Yeah, I think, I'm not aware yet that it's been studied for stroke or peripheral arterial disease. It may have been, but I'm not aware of that. But as a general guideline, you know, cholesterol is related to arterial disease and strokes, so it's not too much of a leap of faith to believe that if you can reduce cholesterol, you're going to benefit those other illnesses as well. So if you've had a stroke, certainly you're on statin medications if the cause of that stroke was clogs in the carotid artery. Same thing with peripheral arterial disease. So, thank you.